So the next panel, well, the next issue we're going to talk about is state licensure. And before we have the panel come up, I wanted to backtrack a little bit. We were going to walk through our state licensure legislation yesterday, but we ran out of time, so I wanted to take the opportunity to walk everybody through that legislation right now. Just to give you a little background, as you probably know, Kentucky and Indiana have passed licensure bills for diabetes educators. The regulations for the Indiana bill, even though the bill I think passed about 2 years ago, Jasmine? Yeah. The regulations are still being written. They may actually be done sometime next week, good Lord willing. So that would be great. The current activity around licensure is that Florida and Pennsylvania have introduced licensure bills during their most recent legislative sessions. So I wanted to walk you through some of the key provisions that are common in both of those pieces of legislation. And I will say this, you know, if you look at the bills back to back, they're not identical. And the reason for that is, you know, each legislature has their own culture, has their own way that they like to draft bills. And so for that reason, the bills can be slightly different. But basically, these are the provisions that are the same in both of these bills. The licensure, so this is really the intro to the requirements this is out from the Florida bill, the Florida House bill. And it says that licensure requirements to qualify for licensure to practice as a diabetes educator, a person shall submit, blah, blah, blah. But here, these first two, these subsections 1 and 2 are what they call in legislative language grandfathering clauses, or grandmothering clauses, but typically grandfathering clauses. And basically it says, if you already are a CDE, an active, and that means you're up to date with all of your continuing education requirements, or you have your BCADM, you are grandfathered in to the law and you will receive your license. And next, for these two bills, what we did is we took the requirements that NCBDE already has for professionals. So let me just state that first, that if you already meet the professional requirements as outlined by NCBDE, and they list all of the professions at NCBDE, you can then take the exam, it would be the NCBDE exam, which you then have to pass. And it would not mean that you were CDE, it would mean that you passed the licensure exam for that state. So let me just go through that again. So in order, let's say, to get your license in Florida or Pennsylvania, you have to be one of the professions that's spelled out as by NCBDE, and then you would have to take the NCBDE exam and pass it. But you would not have your CDE, you would have your license for that state. So we worked with NCBDE, they agreed, we'll offer the exam, but you won't be certified, you'll be licensed. The other requirement, and I'm sure many of you know this, in order to sit for the NCBDE exam, you have to have 1,000 hours of experience. We talked to them, and it's been lowered to 250 in order for you to take the exam. And the rationale behind that was, you know, one of the biggest impediments to getting people to be CDEs was the 1,000 hours. So that's been lowered to 250 as a way to try to get people into the profession.
Is that just for the licensure, or is that for the CDE?
For the licensure. Yes.
The exam, is it the same?
It's the exact same exam. Yeah, it's the exact same exam.
When will that be ready?
What's that?
Someone can take that and get that.
Well, whenever the licensure bill passes.
Could you please repeat?
Oh yeah, could people step up to the mic? I think that might be helpful.
Or repeat, that's all.
Yeah. Yes.
So if an individual takes the exam for licensure, then they want to become a CDE later. They have to take the exam again after they've gotten 1,000 hours, or they just get their 1,000 hours?
They get
and
their
then they can
1,000
get their
hours, and
certification?
then they would get their CDE.
Okay, so that's a good incentive then. Okay.
Pardon me?
That's an incentive then
Yes.
for them to go on and get that.
Yes. Okay, so, I mean, it's actually a very simple piece of legislation. We tried to make it as simple as possible, and much like, and this again is just sort of going through the other list of professions that were spelled out in a little more detail. In Florida, as opposed to Pennsylvania, when we drafted the Florida bill, we had to go into excruciating detail about the professions because under the Florida statutes, you've got to spell all of that out in brain-numbing detail. So when we introduced the bill in Florida, and Bridget can talk about this in a little more detail, we ended up in a fairly big fight with the legislature in Florida because overall they weren't that thrilled with licensure, but we really made some headway on this, and here's why. Well, let me talk a little bit about the roadblocks. So in Florida, when we introduced the bill, our bill was sent to a subcommittee in the Florida House, and there was a representative there, Representative Corey Pigman, who oversees all the licensure legislation in Florida. And he was adamant that he did not care for this bill, did not like it, didn't want it to move. So that became a very big philosophical and political roadblock for us. He happened to be very conservative, and he said, you know, Florida just doesn't like licensure. We don't like extra regulations. And he said, to give you an example, our governor, Rick Scott, just came to us and said, send me a bill that gets rid of at least 500 regulations. And here we are coming with a regulation bill. It makes it difficult. It was a difficult argument to make. And, you know, I suspect, and I don't want to generalize here because we've been hearing all weekend, you know, we had Representative Tryon up here, a Republican, very pro-diabetes and diabetes education. But I think what we may run into, in particular in the South, is that there really is a mood towards not wanting to do more regulation, and that could be an impediment that we're going to run into continually. But what Representative Pigman said was, we will do licensure in Florida provided there are 3 steps. And the first one would be registration. That would be you voluntarily register yourself as a diabetes educator. There would be no board. There would be no discipline. If you injured a patient, the only recourse they would have would be to sue you civilly. There would be no criminal aspect to that. The next maybe a couple years later, we could get certification, which would be the state would actually check to see that you actually were a registered diabetes educator. And the last step would be licensure, which would basically mean that there would be a full board, a full medical board to oversee licensed diabetes educators. Now, what's interesting with registration is if we could pass a registration bill, that would allow us during the regulatory process to develop a scope of practice. So that's the one thing that's very, very promising about going the registration route, is we would actually be able to write in a scope of practice. Now, I will say in Florida, one of the things that, I think we'll get in a little more detail about this during the panel discussion, is that our members did a fantastic job of reaching out to their Florida legislators. We were told, we introduced the bill in the House and in the Senate. In the Senate, we were told, and it went to another committee that was not very happy about our legislation, you guys will never get a hearing on your bill. We won't even give you a hearing, let alone pass it. The president of the Senate has a daughter who has diabetes. He came to us and said, if you guys give me enough phone calls and write me enough letters, I'll go to the chair of the committee and tell him, you got to hear this bill. So that's what we did. We ran press in his district. We beat up on him a little bit, and he responded. Chair of the committee said, I'll hear your bill. I'll give you 5 minutes. That's it. did the same thing. Our members reached out to him and those committee members and said our bill should get a fair hearing. In the House, Representative Corey Pigman again said, I don't want to, I'm not in favor of this bill. We ran an op-ed piece in his district newspaper. Our members reached out to him, reached out to the committee members. And when I met with him, he said, well, he did not appreciate that we ran an op-ed piece in his district. But it got his attention. And he switched from being opposed to the bill to saying, if you do registration certification, then you guys can do licensure. So it paid off. The work that our members did really paid off in Florida in that regard. So again, I talked about registration. Like I said, it has to be voluntary. We'll permit those who already hold an active or current CDE to be considered a registered diabetes educator once they register with the state of Florida. And again, if you wanted to say you were a registered diabetes educator, you would have to take the exam. And you'd have to have the 250 hours of experience. And then certification, again, that would be the state of Florida would validate the credentials of those who claim to be RDEs. Those who misrepresent their registration would be fined. And then the last one would be licensure, which would constitute an entire board. So it would be like every other medical board that your state has. So any questions on that?
Sorry, I said any questions. I have 700. Wildly complex in one state. Now let's translate it to 50. So
Yeah.
I don't think that it is wildly complex. As those of you that have been through this know, and there are questions that pop up. I mean, Kentucky has led the way. Indiana has led the way. We've learned a lot in those processes. But as those of you that have been engaged know that once you answer one question, it causes 3 other issues over here. This is not a simple process.
Yeah.
But that said, the benefits can outweigh the challenges. Sorry, that was it. I've got to roll
Okay. When I started looking in, and Kentucky does have a scope of practice, but when I started looking into scope of practice, like my nursing in Kentucky says, please see the ANA, the American Nurses Association scope of practice. So as we go forward, so that we are, and I know that each state has to have individualized things, but I think the scope of practice is pretty much, could be very similar. So and I know that AADE has a scope of practice, I think, for pharmacists, but I'm not sure we have a scope of practice for diabetes educators. Are we thinking about that?
Do you want?
Maybe I'm going to
Yeah.
We can do it together, and I'll sit, you stay.
Okay.
Can we turn this mic on? I just think I'm going to end up getting sucked into this. And so I might as well sit and do that. Yeah, well, I mean, it's important, and there are a lot of questions. And the whole issue of scope of practice, as we've moved forward, is one of the things that the board's very concerned about and watching closely. It doesn't do us much good if we've got a scope of practice in Kentucky and a different one in Washington and a different one in Florida. And that's, I think, a learning that came out of the Academy of Nutrition and Dietetics, because as they're now looking at, how their process has unfolded over many, many years, that's something that causes them a degree of difficulty. So we are looking at that. But again, while your scope of practice in Kentucky may reach out and reference the ANA scope of practice, it's still the state that defines that scope. So they've built that in. And I think if that's where we're pointing, then maybe we should go back and take a look at there as well. Yep.
And one of the other things to note is that you can see when we introduce legislation how it changes. When you get down to negotiating a scope of practice, you're in negotiations. I mean, it's just because this is the way that we think a scope of practice should be. You always have the possibility that everybody else is going to jump on board and say, well, no, we don't want this, we don't want this, we don't want this. It's something, yeah, it's the sausage making. It was Otto von Bismarck, who was the Chancellor of Germany, who said, laws are like sausages. You don't want to see them being made.
I never thought in my career I would hear people quoting Otto von Bismarck.
I have a question. Have any of these states that are pursuing licensure, do they have a sunrise sunset process?
We'll talk about that during the
Okay.
the panel discussion. Pennsylvania has an extensive one.
Hi, I'm Tammy from California. First, I want to tell all the states that have gotten this point, congratulations, because this has been a discussion at AADE for, I don't know, beginning of time, it seems like. So congratulations to all you guys. Just a quick question, because we've actively talked about doing this in California, so I just want to make sure I'm clarifying in my mind what you're saying. We all embrace our paraprofessionals. We know they're there. We want to make sure that our paraprofessionals with us are teaching the AADE, Healthy 7, and evidence-based practice. So if I'm understanding correctly, what you're saying is that for the registered diabetes educator in Florida, you come in with your CDE or your BCADM, okay? And for others, they can come in and take the same exam, and they're going to be considered registered diabetes educators also?
Yes.
So they'll be parallel in what they're able to do.
Yes.
But they don't have the hours or the experience that the diabetes educator does. I don't understand that. I'm sorry. I just don't. Is that where we're hoping to have that little bit of time that scope of practice can be written?
Yes.
Okay.
Yeah.
Because to me, it feels like we've almost watered down the CDE by only having the 250 hours versus, when I took mine, I had 2,000 hours. So I've had my CDE for a long time, and I have talked to the National Certification Board, and they've said that there has been a decrease in first-time pass rates when they went from 2,000 hours to 1,000 hours, and now we come down to 250, but they don't have to take the exam. But all licensure means is they get to bill the GO 108, GO 109 codes, basically. That's another part I'm missing.
Well, and don't forget, licensure is a minimum standard, and that I think is very difficult for our members to understand, and I can understand why. You're all providing clinical services. The information someone with a license provides needs to be consistent with what someone certified would be. But that certification, that CDE credential, is intended, and I say this frequently. I don't think anyone that took the CDE credential thought, "Wow, I've met the minimum standard." No, you've met a higher standard. And it really is just that difference in hours. Quite frankly, if it were to me, I would like to see that differentiation be slightly different, but it's working with what we have. So that licensure piece would really be the examination and a smaller group of hours. You would need to meet that higher number of hours standard to get your CDE credential, which is intended to be a higher standard.
So hopefully the panel will be able to then explain why we're really, because I want to promote AADE. I'm here to support. I just need to wrap my head around it. Why we're supporting the RDE without the CDE to be able to be licensed. Because California is going to bucket whatever we do. It doesn't matter. And so we have to be on board to even understand it. So anyway, everybody else that's already got it, congratulations. And I may come spend the night with you and figure out how you're doing it.
Ready to go to your panel? So I'll make one final comment before we get ready to go to the panel, and that is, I think one of the learnings that we have come away with in the process over several years is that there needs to be, prior to engaging in licensure, there needs to be a much greater depth of information, understanding, communication to the members about this, and real buy-in from them. Because I think what we found in each of the states that we've gone through is we've initiated the process, we've put out information, we've tried to engage the members, we have moved forward with the legislation only to find that at the 11th hour, when people realize that, oh my God, licensure has been approved, it's going through, then they begin to ask questions. That's a real challenge because a lot of the work has been done, the groundwork has been laid, we've made commitments to legislators, and that process needs to be reversed in order for us to be effective, which means that groundwork laying time has to be much more significant. And quite frankly, we're going to have to grab people by the collar and say, you need to listen and have an opinion on this, because something's going to take effect that is going to impact you. And people are not, people are not interested. We've all got a lot on our plate. People are not interested and engaged until something is on their doorstep.
You know, when I worked in political campaigns, the rule of thumb was, everybody gets those mailers, right, from a candidate. People don't pay attention until they get the fifth one. Then they start to, I think I've seen this before, that the outreach to membership has to be extensive, and it has to be constant, and it'll probably take a couple years to get people to the point where your membership feel that all the questions have been answered and they want to move forward. Because here's what you don't want to have happen. You don't want to introduce a bill, your bill's in a committee, and who comes up and testifies against it? An AADE member. Then your bill's sunk. It is absolutely sunk. And if, for example, a legislator gets 10 calls from people who support the bill and get 20 calls from people who oppose it, who do you think they're going to go with? They're going to go with the 20 calls opposed to it. So to back up Chuck's point, you really have to do a lot of work with your members so they're comfortable with it. Not only are they comfortable, but they're going to advocate for it. Because it was, as we saw in Pennsylvania and Florida, you're going to have a lot of people coming out in opposition to your legislation.
So why don't we take the next two questions, and then we'll go to the panel. And just maybe if I can make a prefacing comment, I think both the blessing and the curse that we had in Indiana was we had strong support. The legislative lobbyist that was brought to the table for us was one that our corporate partner had worked with. They had, legislative ties that could move it, so it moved very quickly, and it was done. And then our members kind of said, "Well, it's done." Yeah, so I think we need to slow the process and be much more deliberate about it.
I'm Tammy from Colorado, and I kind of wanted to echo the concern of Tammy from California in that I think AADE has done such a great job in the past of building up the importance of the CDE. I've used the materials working with primary care providers, why you want a CDE on your staff, because of all these things we can bring to the table that your non-CDE trained nurse or dietitian or PharmD may not be able to. And I guess my concern, I think there's definitely room for debate. Is 1,000 hours too many? Are we asking so many that it's too hard to bring enough people in? But it seems like I would think AADE would want to keep saying our folks with diabetes need and deserve this level of care that CDEs are able to offer. And it to me feels a little backwards that we're saying, or you can kind of take this version that has 1/4 of the hours. I'm not saying 1,000 hours is the right number of hours or the wrong number of hours, but I just feel like everything that I have been preaching to my organizations and everyone, I feel like I'm now kind of going against that. And I feel like the American Nurses Association recognized this way after the fact when we had the LPNs and we had the one-year degree nurses, and now they're saying, you know what, we really think that 4 years is really where we should all be, and they've realized that the quality was not the same, and I just hope we're not kind of like shooting ourselves. I mean, AADE is this advocacy organization for us as this profession, and now it almost feels like maybe we're kind of undercutting our worth a little bit, but maybe I'm
and I think that's
it's
a very valid perspective, but I would say that we have to take a step back and have a realistic view of what is and not what we think is. First of all, I would say I agree 100%. The CDE credential is the gold standard at this point, and where we would like everyone to be. In fact, we just had a meeting with Cheryl Traficano out of the NCBDE, which is really only about 4 or 5 miles from here, long way from the office, but in the traffic. But we meet regularly, and we specifically talked about what can AADE be doing to help encourage, promote the credential. So we are absolutely there with you. However, today in Illinois, I can be a diabetes educator. And believe me, you don't want me to be. I mean, I've got no background, so there's no standard. So that's one thing, and I think we all recognize that. But I think the piece that's sometimes lost is, right now, a little over 50% of our AADE members, who you would say are the next step of engaged or most engaged educators in their profession, don't have the CDE. So we talk about diabetes educators as CDEs, but only about 50% of you are. So it's, while yes, I agree, let's push more people. I think we often speak from the realm of all diabetes educators are CDEs, and that's just not the case.
But maybe then it's time to look at that CDE 1,000 hours required and say, we got this, then let's make that 500 hours. Or let's do what we need to. Because now we're saying, well, you can go CDE, you can go LDE, and one can kind of do the same thing as the other. Let's pick out a number of hours that we say this hours make sense, and let's just say everyone should have that.
So now we get into the complexity. Yeah.
Next
Let's
question?
do one more question,
Yeah.
and then let's go to the panel, and there'll be much more opportunity for those of you that have been in the heat of it to talk about this.
I'm Vanessa Patty. I'm a nurse practitioner. I'm a licensed diabetes educator in Kentucky, and have been at the table quite a bit with discussions about what's going on in Kentucky. Kim knows that. Having been, the first state, we've learned a lot, and we continue to learn and continue to grow, and a lot of efforts being put into refining it. So I just want to say, we're health professionals, and health professionals work on a level of novice to expert. That's been spoken of for years and years and years. And I have, and many of my colleagues have been big proponents of testing for licensure. I told our legislators that aside from a fishing license in the state of Kentucky, everybody has to take a test to get a license, okay? However, it disappoints me that the NCBDE is choosing to use a competency level of an expert for someone who we're bringing in at a beginner's level, at a novice level. They must have a pool of 5,000 questions that it seems that they could pull together a basic entry exam to measure someone's novice or beginner level of knowledge. Then that person goes forward, gets their experience, those hours in, and then becomes licensed by their state. I do think it waters down the CDE. I don't have my CDE. I'm a nurse practitioner. I don't need my license as a diabetes educator with my credentials, but I support this because I do believe there's a long-term goal that we will achieve. But it really disappoints me that they are not doing something at a different and looking at it by the level of who you're bringing. Are we bringing people in expecting them to practice at a level 3 competency of the AADE competencies? Or are you bringing them in at a level 2? And if that's the case, the examination needs to accommodate that.
And I think that's a reasonable observation. I think perhaps over time we can go back and look at that. And I think NCBDE would be open perhaps to looking at that. I can't speak for them, but the reality is what they've said is if you pass licensure in other states, they're willing to open the door and utilize this examination, which quite frankly gives us a pathway that wasn't there. So they're opening up and giving us some options. I think over time, if multiple states did pass licensure with the exam, that would give them the wherewithal to have an argument to go back and review and evaluate that. I know that's a bit after the fact, but the cost associated with exam development is huge. I mean, I'm sure they're putting multiple hundreds of thousands of dollars into that exam on an annual basis because you have to develop the tests, you have to test the questions, you have to have a psychometrician evaluating how those questions perform. It's really if anybody's interested in statistics and examination and credentialing, it's a fascinating area. Well, I thought it was. And I don't like statistics, but it really is. When you look at a question, you say, well, I'm not going to go that route. Anyway, I think it's a valid comment, and I think it's something that we can talk with NCBDE on, but I think we'd need to pass the first state that's going to, use that examination for, licensure before we could get too far.
Can I ask our panel to come up?
Yeah, that's a panel. And
Can you hold your question and then until we, do you mind waiting?
It'd be a good segue for the.
So I just want to introduce everybody very quickly to our panelists. Pat Adams is an RN and a CDE since 2003. Pat was the Pennsylvania CB chair in 2012 and 13. In 2013, the Pennsylvania CB was awarded the My AADE Network Coordinating Body Award. Pat has been the program coordinator for the AADE accredited program at Einstein Medical Center, Philadelphia campus. Pat has been extremely diligent and passionate about trying to move licensure forward in Pennsylvania, and the bane of her existence has been the Sunrise Report that is required in Pennsylvania. Kim DeCoste has been a diabetes educator for 31 years. She currently is contracted with the Kentucky Diabetes Prevention and Control Program, where she is the Diabetes Education Accreditation Program Coordinator. She manages a statewide umbrella accredited DSME program for local health departments in Kentucky. She was appointed by the governor in 2011 and reappointed in 2014 to represent registered nurses on the Kentucky Board of Licensed Diabetes Educators. She was appointed by colleagues to the Kentucky Board of Licensed Diabetes Educators to serve as chair of the board, and continues to serve in that capacity today. She is a past member of the AADE Board of Directors and has been a longtime advocacy volunteer for AADE, and she holds the distinction of having license number 001 in Kentucky. Jasmine Gonzalvo, PhD, BCPS, BCADM, CDE, as a clinical associate professor of pharmacy practice, College of Pharmacy at the Purdue University. She received her pharmacy degree from Butler University in 2005. Her clinical experience for Eskenazi Health involves provision of cardiovascular risk reduction services operating under a collaborative practice agreement for FQHC. In 2015, she was elected to the board of directors for AADE. She's held a variety of leadership positions for AADE, as well as serving on the credentials committee for NCBDE. She currently serves as a legislative chair for the Central Indiana Association for Diabetes Educators. And BRIDGET Jennings has been a registered nurse since 1990 and a certified diabetes educator since 2006. BRIDGET became involved with diabetes education and self-management soon after she was diagnosed with type 2 diabetes in 1992. She has worked and volunteered in a variety of diabetes settings, including community and faith-based organizations, population-based education initiatives, and individual and group education for people living with diabetes. BRIDGET provides continuing education for healthcare professionals and peer support education for community health workers. In addition, her professional and community work include both diabetes self-management and diabetes prevention as a Centers for Disease Control trained diabetes prevention program facilitator. So thank you very much for agreeing to be on this panel. And I have a number of questions I would like to ask, and then we will open up the floor to questions again. So I'd like to start very generally. And if you feel that somebody has already answered a question that I've asked, feel free to answer, but you certainly don't have to. So I was wondering if each of you could talk very briefly about what the history is of why your state is or was interested in passing a law to license diabetes educators. Kim, would you like to go first, since you were the first?
Okay. Well, you all know a number of years ago, the conversation came around, why isn't our federal legislation passing? It's not going anyplace. We keep on getting the answer. And at that time, Martha Rinker and James Specker were with us in the AADE office, and we're meeting with CMS, and CMS said, you don't have a license, you don't have a definition, you don't have a scope of practice. So with reimbursing a diabetes educator, there's really no definition of what it is that we're reimbursing. You all know Kentucky's long time been a very active state with AADE, and at that time, Deb Philman was, I believe, the incoming president. So she was president-elect of AADE. I was very active on the advocacy and on the AADE board, and we were approached, would we be the model state? So I think our organization was interested in moving forward in a way to get diabetes educators reimbursed. And I talk about my Daniel Boone story because he's from where I'm from, or he set his fort up there. And basically, we were the pioneers. So we were asked to be the first to step out.
Whoever wants to go, please feel free.
So, excuse me. Pennsylvania's been working on this issue literally since about 2012, and our very first state meeting with the transition of the My AADE network. I was the CB chair and was hosting a Q&A session at our state meeting in a big theater, doing my Vanna thing, running around, and really started realizing I always thought that everybody was a CDE. I worked for somebody who sat on the board of directors of AADE, and I was kept on a real short leash until I had that CDE. But I realized across the state, and particularly many rural areas, there are many people out there, they're well-meaning professionals, that they do not have the opportunity to have that CDE credential. Fast forward now, as we're in healthcare reform and this whole medical center home, and health and navigators, and I'm really do not mean to insult anybody if you are doing the navigating job. I'm sure it's very difficult, but in my health system, the navigators really have no diabetes training. And I was sent a spreadsheet last week about this particular nurse, RN, BSN, MSN prepared, who is working in an internal medicine office in Philadelphia. It's a very urban area of where we're working. And this whole spreadsheet, there's all these notes about how she instructed insulin, instructed lifestyle change, and the nurse practitioner that was sharing this is like thrilled. And I'm saying, like, well, what's her credentials? What extra training? I'm not saying she's not intelligent, but was the 15-15 rule included with that insulin training? What else? So I see that the licensure really needs to establish that scope of practice, that that entry level, the beginning, before somebody can hit to the certification. So that's what's motivating Pennsylvania, and that's been our path so far.
Jasmine?
Just to pair off of what Kim said, being that they were the model state, I would, being entrenched in this right now, just to give you an update on where Indiana is, we have our final rules hearing on May 26th. That is very soon. And and to allude to what Chuck said, everything happened really quickly in Indiana, and the initial statutes back in 2013. So it was about 3 years at this point, but they got passed really quickly. And I was chomping at the bit when all of those questions were being asked about, shouldn't this look like the CDE? Well, let me paint this picture for you. In Indiana, the rules are exactly basically the CDE. We don't have the exam, but we have the 1,000 hours. So as I've been involved in this discussion, I said, I had a lot of the same questions that were being echoed here. What I did was, okay, Jasmine, take a step back, and how does this help the patient? How are we looking out for the patient? I always, go back to the patient, and how do we help someone with diabetes? And I actually did a study, and I don't think I'm answering your question, I apologize. But the study that I did was, okay, in the state of Indiana, how many community pharmacists, so your pharmacists that work in Walgreens, whatnot, that's not my practice setting, but I just did that study. It was less than 1%. It was 6 out of 1,000 in the state of Indiana had their CDE or BCADM practicing in a community pharmacy setting. So then I asked myself, with that number, what are we doing if licensure looks exactly like the CDE? What does our future pool for patients with diabetes, how are we advocating for our patients with diabetes when we're limiting the pool to look like less than 1%? When I answered that question, I was able to hop on board with that idea that licensure is the minimum requirement, and we need to increase access for our patients with diabetes. And I'm going to pound the table because because I've actually been forced to take a stance because I need to, represent AADE. I need to represent patients with diabetes. And how do I do that? And we're doing that on May 26th. So as is, our rules in Indiana say 1,000 hours. There's no exam. We were previous to those conversations with NCBDE, but we have the 1,000 hours plus completion of the core concepts, or if you're a CDE or BCADM, those are the eligibility requirements for licensure. So there are a couple of groups in Indiana at this point that are actually going to be advocating for lowering those requirements, and I think it was interesting that 500 hours got thrown out there because that is what I think, and who knows what's going to happen in the next couple of weeks, but 500 hours is being proposed to be the decrease from the 1,000 hours. And that seems more reasonable and tangible for being the minimum requirement for licensure for diabetes educators. So just to give you a glimpse as to all of these complexities that come into play, but when that was how I challenged myself. When I said, okay, is this diluting the CDE? Is this diluting the quality of diabetes education? I went back to the patient, and that's how I wrapped my arms around the idea of licensure.
Bridget?
Okay, well, first of all, I have to agree with Kim, Pat, and Jasmine with everything that they've said. And then in addition, when we started looking at licensure in Florida, we kind of looked at the landscape around, and programs were closing all over the state. And people were losing their jobs. And in addition to that, then people with diabetes were losing another access to diabetes education. So, fortunately for us, those of us who are CDEs, then we always have our primary license that we can fall back on. However, the passion and the need is for diabetes education, and not just any diabetes education, but quality diabetes education. And when I hear the discussion out here and we talk about watering down and limiting it to 250 hours, and that we're sort of in an arena where we're trying to, where we eat our young, kinda. And so we're looking at ourselves and other professionals as the enemy, if you will. And my concern is that right now, except for Kentucky, anybody can say that they are a diabetes educator. So who's providing diabetes education in these physicians' offices now? It's the medical assistant who the provider says, my nurse is going to come in and talk to you about diabetes. It's not a nurse. Or my nutritionist, my dietitian is going to come in and talk to you about diabetes, and it's not a registered or a licensed dietitian. It's the medical assistant. I have no problems with medical assistants and ancillary providers being part of diabetes education. They have a very specific role. They can teach task. They can teach a lot of things that we're asking our patients to do. If we're asking them to do it, then someone with a medical assistant certification can certainly teach how to use a glucometer. Now, it takes that clinical insight, that clinical experience, and clinical judgment to talk about when, where, and then what to do with that information, not just with glucometers, but with everything else. So fortunately or unfortunately, there are enough people in the United States that have diabetes that all of us can have part of that, and we need everybody working with that. So with the passion for those of us who are diabetes educators, and certified or credentialed diabetes educators, because we all talk about the CDE and we leave out the BCADM. Well, so the quality is what the issue is here. So I think that if we take a step back and we look at that in Florida, now we went to our membership and we had an uphill battle with that, but when we started looking at who we were trying to fight against, we're talking about another professional who has some clinical clinical education and practice and experience versus someone who doesn't. And I'm still talking, then if we wanted to compare the medical assistants to the person that comes in the Whole Foods store or who is at the vitamin shop providing diabetes education and trying to sell, all these vitamins and these wonderful things, there's not a clinical part of what they're doing. They have no clinical background. They have a script and then they are trained by their company to come out and do that. So I'd like for you to take a closer look at, in Florida, if we say we pass the test, that's where the knowledge is, and we know that the experience then is what helps us to put that into practice. But we have to have that basic information first. So we kind of went back and forth about the 250 hours, but for the state of Florida, that would, you would be able to be licensed. Now, again, the certification is, if you want to get that, then you have to go back and get your additional hours and that. But for the minimal there to be licensed, that's what we're looking at. Now, in the state of Florida and anywhere, a license has a legal definition on it. A certification like the NC, that has no legal definition in any clinical arena, because it just says that this test, that we passed this test, and we're very smart because we did pass that very hard test. However, if somebody has a complaint against us as a certified or a credentialed diabetes educator, they're not going to NCDB. I don't know what. Yes. Yeah, the certification, because we have those two things. So they can't go to them because they're not a regulatory body. They are a credentialing body, and they are an excellent credentialing body. All right, so without that, we're never going to get anywhere on our federal bills, and because Medicare is not going to say, okay, well, yeah, you can do that. We have to have that scope of practice, the license. There has to be a legal definition, and there has to be a way for someone, just like with any nursing board, dietitian board, for somebody to be disciplined if there is harm caused. And so that's where we fall into that. Why there's a difference. So legally, a license is going to trump a certification. A certification then is just going to say, yes, we have the tiara also. And so that's where we started looking at it, is then if our programs are closing, who is providing that education? And in the state of Florida, anybody can provide that.
Yeah. One of the things that Bridget said reminded me of something, that the organizations that have come out as opposed to our legislation in Pennsylvania and Florida have been the vitamin groups that Bridget talked about. Those have been the most eager advocates against our bill, and because they don't want any sort of restrictions on what they're doing and being able to say that they're diabetes educators. The next question I have is, can you please describe the process your state developed in order to gauge the interest of your members, get them to participate in the process, and so if you just start with that, to gauge the interest of your members and to get them to participate in the process. Sure, if you want to.
Before I talk about the process, I want to mention something that Chuck brought up a few minutes ago about people making sure that they, I guess, have a voice or advocate for their opinion during the legislative process in the beginning. So I I think in our legislative process in Kentucky, we had one person that wrote a letter to one of the representatives who Bob nicely put up there, our senator and representative, wrote a letter, and that was the only comment of concern that came out of the licensure legislation, was one. And then after it passes, then all of a sudden people become more interested, and they're too late because it's law. So in looking at the process, what we did was we began with our statewide diabetes coalition, the Kentucky Diabetes Network, and we had a presentation, and it was not as much on licensure. We introduced the licensure concept, but it was surrounding the lack of a scope of practice. So it was presented in Kentucky first as a scope of practice issue, which it really is, and I think that we need to look at it in that way, and I think Bridget gave some good information on that. So we went to our statewide coalition, spoke there. We went to and offered to go to and be accessible to all of our chapters, and we still had chapters at that time. And in Kentucky, we have 3 or 4, really, if you count the one that's attached to Ohio, to Cincinnati area. We had a town hall meeting phone call, and if I remember correctly, I think we had 11 people on that call. That counted me. That counted probably James. You know, so we had just a few people come onto that call, and we were always available for questions and open at that time to those. So that's really how the process began. So it was based on a conversation with a lot of the different stakeholders, and then at that time we looked, and Bob Babbage was the person who you all met yesterday who helped us carry that legislation, because he's Mr. Diabetes lobbyist in Kentucky. So he was the person that helped us align with the correct people to do that. You know, he mentioned a little bit about the people who carried the legislation. You have to look at what somebody who cares about it. Unfortunately, we weren't like Illinois and has this wonderful caucus, because you would know exactly where you need to go to discuss those things. Senator Kerr, and this is not violating anything personal on her, but Senator Kerr lost her mother to diabetes in a very, not a good way. It was, you know, so she saw the purpose in it. So we went there. We also, you know, as she said, we went to both houses. We had a Republican and a Democrat. Unfortunately, we started with the Democrat, who was the other woman, the dark-haired woman yesterday, if you remember Bob's slide, was Senator Kerr. We started with the Democrats in the House, and then our Senate leader, who was a Republican, refused to bring the legislation forward. He had type 2 diabetes, and he told us only brown-eyed people get diabetes, so it's really not as big of a problem as we were trying to make it. He said it directly to Deb Philman, so I think her teeth fell out. She left the room, and we talked about how stupid he was later. But anyway, so the next year we came back, we introduced it in the Senate, where we had a Republican, which was Senator Kerr, and no, he was not going to tell her no, we weren't going to bring it forward, because we had passed the House the full, you know. So you look, and you have to be political in the way that you bring it forward and bring it to your legislators and stuff as well. So that was kind of how we started.
So in Pennsylvania, we really did start off with an education effort. Using the My AADE network, we sent out blasts, little facts. Did you know? For several weeks and months prior to our, we also had a town hall call. I think we had 76 people participate. So I think as membership sees this expand, more and more people were participating, but 76 out of 600 members still was not enough. But we also used SurveyMonkey. We did one before we started this education process. We did one after. A lot of it has just been one-to-one interaction across the state. We have a very popular state meeting, so that is a forum where individually we can answer questions. So that's how we did it with our members. The actual political process in Pennsylvania. So yes, we have a sunrise requirement. This is a 2-year job. And it's as well-referenced documentation and paper as you would have for any, I think, peer-reviewed journal. Of course, we haven't submitted it yet because we do have a diabetes caucus. We also, Lisa Laird, who's our immediate past chair, and myself sit on a diabetes action network now that has been restarted in the state by Novo Nordisk, and she was presenting to the Diabetes Caucus this information, and one of the members, who is a 65-year-old type 1, Representative Tallman, was really thrilled with what he heard, and he stepped up immediately and said, you know, he was behind us completely. You must have a professional in your capital. You have to have a lobbyist. We would never be able to do any of this without a lobbyist. So she has been our feet on the ground and getting the legislation written. We've had, I can't tell you how many calls. Next month, a week from Monday, we will be testifying to the Professional Licensure Committee. We have a bill written. Representative Tallman introduced it. So we are going to take that opportunity of questions and answers, and unfortunately, we do have some opposition. They will be testifying, but that is also going to help us refine this document even more before we submit this into the Department of State. This is our sunrise evaluation. It's a 25-question, it's developed by the state, our Department of State, on why do you think we need to have a license? What will happen if you don't have a license? Every question you can think of. If I would have one piece of advice for anybody, as important as our CMS legislation is, the one big piece I've been told, do not mention reimbursement attached to this to any license. That will shut them down. That will shut down anybody. They think it's extra cost. The insurance company lobbyists will be out against us and everything. So it's really about the consumer protection.
Oh, yeah, Jasmine.
I really want to speak to engaging the members early on in the process, and because honestly, Indiana is a good example of what not to do in a lot of ways. We don't have really active members. We don't have 70 people in this discussion. Arguably, I'm the person involved in licensure, and then there's one other person, and there's kind of one other person, but really we are the licensure people to talk to in Indiana, and that makes it difficult. And so I would like to echo what Chuck said earlier, is grab those people by the collars and say, you're gonna care about this. I promise you, you're gonna care about this. And those groups in your state that maybe aren't active AADE members, but they might be, for example, the Indiana Pharmacists Association. They actually have strong feelings about this, and now, right? So those of you that haven't had are just starting the process, grab those people by the collar, because late in the game makes things a lot more difficult, and people are a lot angrier at that point because there's little room for change late in the game. So speaking from that point of view, diabetes educators are interdisciplinary professionals, so grab those people from your local organizations and get them involved in the conversation. So administrators from those places, so that they know the significance of what's happening.
Bridget?
So two things, because I've been, I think, probably most engaged around some of the issues in Indiana. We did some things wrong, and I think, well, we did one thing right, which covered my derriere, which was, what if we had to do it all over again? What it did move quickly, and in hindsight, it's 2020. So this is, hindsight is 2020. This is not critical. This is just an observation on my part. I think the individuals and the lobbyists and our support internally in Indiana moved too quickly. I think if I were to do it again and I knew where we were in the member engagement process, I probably would put a brake on and say, wait a minute, we need more engagement here. But the one thing we did do right is there were opportunities for engagement. And so when the regulation began to be developed and the members began to come out, the first thing was, nobody, and I started every call with, let's just review the history. We had 3 calls to talk about licensure. We were at your annual meeting. We were 2 annual meetings. You were all invited to the State House. So the opportunities for engagement were there, so it at least stemmed that time. We tried to engage people, but it's just not something natural that people want to do or see. So the one thing we did do was we documented those. James had documented every opportunity for engagement that was there, so we could at least put that aside. That didn't mean that there weren't real issues that the members had that needed to be addressed and dealt with, but it got us out of, you know how it is. The saying in research is, if you don't like the results of the research, criticize the methodology. Well, we took the methodology out of this because it was a reasonable methodology. It could be done differently, absolutely, but at least we've given that opportunity.
Okay, and so what I'd like to talk about too is both on the member level and the political level, and everything that Chuck said with that happened in Florida too. We did lots of engagement opportunities in that, but where we first started was we went to it wasn't the public policy forum in DC, but we had a meeting in Atlanta. And that's where I really became involved in this whole thinking about licensure as an individual credentialed diabetes educator. And so there were several of us there. We went back, and then right after that was when we changed the platform for how we're run. We went from the chapters to the LNGs to the creation of the coordinating body. And I think by default, I was the transitioning chair for Florida. I think nobody else answered Patty's email to ask what your status was, and I said, I'm here, what do you need me to do? And then that was it. So, but we did have a very good group of professionals from around the state, and then our first job was to get representation from each of our LNGs. Now, Florida's got a lot of LNGs. I mean, they're just geographically, there's a lot of people together, but so we had a lot, and so that was one of our first tasks, was to get our LNG fully vested, if you will, and on board. We started with monthly calls, and then we started talking about the licensure initiative. And when we started talking on the CB level, it was a mixed audience. And so some were like, no, we don't even need to go there, we don't need to do this, and some were, yes, we need to. And so what we did then is I worked with James Specker, who was here previously, and he gave us the information. Now, he didn't try to bias us one way or the other, but he gave us the information. We had multiple phone meetings, and then at our annual on-site meeting with our annual conference, we had a half-day meeting there, and we had AADE, Patty was there, and Patty Mangano, and also James, and then we just kind of, the most most of it was hashing out how we were going to present this information to our membership. Now, mind you, the first goal was not to make a decision on whether we should go forward with licensure or not. It was how we were going to get this information to our membership, because our membership is the one who's going to make the decision whether to move forward with it. So we decided that the first thing we needed was to have a united voice, one voice, and so we met with the CB after that. And even though it was never a 100%, everybody says, yes, let's move forward, we still had some people who were, I'm not really for it or against it yet, but I do want to hear more. And then we had, I think there were 2 that said absolutely not. So through the course of that, we developed a timeline and said, we're going to take this show on the road. We had some town hall calls, but we also made arrangements that I went to every LNG in the state of Florida, and we presented the information. We presented it, and the first thing I said is, I am not here to convince you that licensure is what we need to do. I'm not here to convince you that we should not do it. We're presenting the information just like AADE is doing, and then we will get together and decide. So from that, we went to lots of information going out. We developed our advocacy subcommittee as part of the CB chair, and we met monthly. We did a lot of work on that, sent out emails, because most of our members did not want to use my AADE network at that point, so we were still using these big, long distribution lists from the email and sending them out, but information was going out the way, and we still did it on my AADE network, but information was going out the way our membership said they would respond to it. So then we had our on-site meetings, actually went to some LNG state meetings and presented the information, whether we were presenting as a speaker or we just had a table. Every event that happened in Florida had information about licensure and advocacy on it. So imagine our surprise too, then when it came to, I think it was 2 years ago, 3 years ago, we decided that as a coordinating body, and from what our membership had said, those who were involved, yes, we would move forward with the licensure initiative. Well, I didn't think I was going to be able to get out of Miami, because that's where it happened. It's like, you never told us this, so the people who come for the CEU part of it, they were there because they needed to get their hours, and they had not accepted or participated in any of the other engagement activities there. So we had to circle back a little bit and do just like what Chuck said. Yes, we had this. What area are you from? And, I had the list. No, we provided this to your LNG, and I'm sorry you weren't there. So, however, this is what we need. So we still worked with them and answered questions and did all of that. So it began to be a little bit rocky there, but we were putting out fires and that. But the one key thing is, if any one of your members is being very vocal and they're anti whatever you're doing, you need to listen to that person, because they're one of us and they're feeling that way. So we need to work with them, because if they're feeling that way, somebody else on the outside is too. So don't wish they would go away. In fact, you really want them to come forward during the whole initial process of that. So then when we moved on to the political arena, I agree, the lobbyist is the way to go. And we, when we met with there, it was like nobody in our capital or in the state knew who AADE was. So we started making ourselves known. We started commenting, and we started just providing information, and the lobbyists going around, AADE does this and that. And so throughout the course of that, we realized that, and that was the first year what we were going to do, just make AADE known. We knew that we wouldn't be able to get a bill because by the time this happened, it was already way late. But we were just making our name known so that people knew who we were. And so one of the things we found was that our diabetes advisory council, the governor's council, had all of these representatives from all over the place, very much needed representation, but there wasn't a spot for someone from AADE on it. So as one of the first things that we challenged and tried to do is to let that become something. We need this, we need to be on there. And so I am happy to say that that bill was passed, and so this is the first year that there is an AADE representative on the Florida Diabetes Advisory Council. And so that's really good. So we feel like we're going to be able to make some headway there. But Kurt did an excellent job of explaining the whole process of what happened and what's going on in Florida. And so, we're just a state that doesn't want regulation. We don't tell us what, don't mess with Texas. Well, don't tell people in Florida what to do either. So that's just kind of the way it is, because that's just the way the culture is there. And so what we have to do now is go through that process, and each one of those steps that we have to do, I'm sure there's going to have to be data on the back side of that showing the need for registration and then the need for certification. And again, that certification is different in the state than it is that our national credentialing body is, and then licensure. So we have to go through each one of those because that's the culture in Florida and that's the way that they do it. But again, it is worth it. And because, I've been living with diabetes since 1992, and the things that have changed are wonderful. However, the things that are still being said and still being taught, we've got to take care of that because diabetes is not getting any better. And there will always be, unfortunately, more people with diabetes than any of us can handle. And the way we're doing it now is not working by closing out access for other professionals to be able to provide diabetes education. So I hope that y'all will consider that and think about, let's not eat our own young. Let's worry about those little bitty minnows, if you will, on the outside that are just coming right on in. They have a role, but their role is not our role as a professional clinician.
So we have a few minutes before we have to go, and I just want to try to end on time so that people have planes to catch and whatnot. So if anybody has, let's just take a couple of questions and then...
Okay, so I'll try to be as quick and thorough as possible. I want to thank you all for all the hard work you have done in moving licensure forward. It is truly an honor to be here today. My name is Annie McCoy, and I am a new grassroots coordinator from Pennsylvania. So this licensing is like a train that is going 50,000 miles an hour, and I'm trying to hop on. So I am trying to learn, and I respect everything that Pat Adams and Lisa Laird and Kelly Lent have done in Pennsylvania to get us to this point where we do have this hearing Monday. I do work with a vibrant practice in Monroeville, Pennsylvania at Allegheny Health Network, and I do serve on the local Western Pennsylvania local networking group. So these questions are representing concerns from not only myself, but also many people on the western side of Pennsylvania. And with respect that we do understand that without licensing, we won't have recognition at a federal level, and that's, and all the sausage comments, and it's messy and it's not going to be perfect when it first comes out. With that said, all of us that are applying for this license already have a license. So, I can be recognized by Medicare because I'm a licensed dietitian. So here are the questions. I'll just run them out, and then if you could answer them in a group or maybe even email later, because I know we're running out of time. So in Pennsylvania, why would licensed professionals want a license that only offers title protection at this point. There's no scope of practice, and I say that with respect. I realize that I'm a novice in this, Pat, so it's said wanting to learn.
Okay, if I could please, I don't know if this stands true for every state. There's title protection versus, what's the other? Practice protection. In Pennsylvania, we have been advised that the beginning point, I have argued this, Kurt will tell you, and Chuck will tell you, I have been on the phone calls arguing vehemently for a practice protection bill. But I have been told that as a starting point, because the outcome that we need is a scope of practice, and as a starting point, getting a title protection, and then building that scope of practice and further regulations after the bill is done. That regulatory phase is what is our best point. And that's where it is our beginning point, and we're going to be making lots of sausages in Pennsylvania.
Okay.
Can I? I'm
yes.
sorry. Can I add to that? In Kentucky, we originally made a mistake and only practiced a Title Act. We didn't know that that's what we had done. Our legislators who carried it did not know that that's what had been done even. So when we went back and told them what had happened at the last minute, when my Attorney General representative on our board informed us of that we were trying to do something that was outside of the scope of what we were allowed to do according to regulations. So you want to make sure that it's written correctly. And so we did want a scope of practice, because that's what would protect, to me, you as a licensed dietitian. Let's just say, I don't know, are you a CDE?
Yes.
Okay. Do you ever instruct anyone on insulin?
Sure. Every
Okay.
day.
Well, in Kentucky, you potentially would be trying to practice as a nurse without a license.
That would stand true most likely for Pennsylvania.
So,
Right. I
and
do
all
that
states,
under
okay.
an order of a physician, though, so I'm practiced
So,
under the.
but for you to
protected under there.
be able to do that, that gives you protection as well. So that's where, that goes. I've talked to the people on our licensed dietetics board, and they said that they probably would not really stand behind saying that is within the scope of what a licensed dietitian should be doing under that license. The licensed diabetes educator scope is written in a way that you do what is needed for that patient to be able to self-manage their disease. And as a licensed diabetes educator, who is also a licensed dietitian, that would be something that would be necessary for that management of that. So that's why I think that scope of practice is extremely important. And if that's how the state needs to move forward methodically, I think that that's the way I would do it. But just remember, you still don't have that right to do anything other than call yourself that. You still don't necessarily have the right to teach insulin if that's not within your scope of practice.
And a concern from the nurses in our group is, okay, if we do pass the scope of practice, which I'm all for as a dietitian, it's great for a dietitian to have our scope of practice aligned with the nurses. The nurse's question to me was, why would anybody hire me then? Honestly, in Pennsylvania, dietitians are cheaper than nurses. So
Okay, I'd like
she's
to go.
afraid of losing her job.
Okay, I'd like to address that.
Real quick, so we're going to go till 10:30, and then we're shutting off the mics. And then we'll have our 15-minute break.
Okay.
Okay, all right.
Any questions that aren't answered, if you send Kurt an email, we'll get you an answer.
Yeah.
Okay, you have the rest of them in an email.
So looking at, it goes back to that certification versus license. As a dietitian, you are licensed to do certain things there. You have a definition for that. With your CDE or your credential, for diabetes, you have a document that says you know all of this information. Legally, you do not, that does not entitle you to provide that information. So the certification by the National Credentialing Board says you know that information. You've passed the test to prove it. Your state licensure does not cover those things for a dietitian, like insulin teaching or exercise physiology or any of those other things. So the certification is there, says you know it, but you don't have a state license that says you can do it. That's where the licensed for diabetes educator is important, because it's going to cover all of those aspects that are included in diabetes self-management. So we have to stop and take a look at the difference between the certification nationally and what our individual primary license says. Now, if you're a registered dietitian and a registered nurse, go for it. But if you're just one and it's the dietitian, teaching insulin is outside the scope of your practice. Doesn't mean you don't know how. Legally, you're not supposed to do that.
Next question.
I just wanted to tack on to Chuck and Kim's comment about getting your members involved. You know, our legislation in Kentucky went into place in June or July of 2011. There was no such thing as a coordinating body in 2011. It was something being introduced by the AADE to try to get people on board to do that. And so we didn't have a forum for communication to come into and then get disseminated out to chapters or LNGs back then. The AADE network was in its infancy too, so there was not even a mechanism for things to be electronically messaged to members to tell us what was going on with it. There was no place you could go and look at what the laws were that were being written to even make comment on. So you're at a position today that is far better than where we began, because I am a burr in the saddle of the Board of Licensed Diabetes Educators. Kim will say it, I testify.
I
and
did not say that.
I know, I confess, I have no problem, because, you know, until it was put out there, kind of after the fact, we couldn't see it to really respond to it. So take advantage of that. You have a World Wide Web now that you can use, and the AAD provides you a wonderful forum through the AAD network, through the coordinating body and the structure and its connection with the AADE. So take advantage of that, and I think you'll find that it's a little less painful for you. You won't have people coming in after the fact asking you to change things that you really can't change because the deed is done. So I just wanted to just bring that up to you.
If I could add,
Okay, yeah, I want to add something to
every
that, too.
state we've done licensure in, from Kentucky to Indiana to Pennsylvania. No, good. I'll yell. There's been a degree of contention between members. I mean, because people think differently. We think Republican and Democrat, they have different perspectives. People want to get that out there. That causes me angst and pain, especially when people are colleagues and they're really working towards the same thing. I think what we've tried to build is, you know, that sense of let's find forums to allow people to share their perspectives. I think recently we were on a call in Indiana, and I think Indiana asked Betty to be on the call because they expected her to say, well, they knew that there had been issues in Kentucky. They were the first that were going to be there, and I think it probably shocked you the most when I said, Betty, could you share your experience? It was. and that was, you know, we're all learning. We're all learning.
Marilyn, can I say too, to make sure, and I'm thinking that Kurt and his team probably would not be working strongly with these states, but you know, you're reliant upon the people in your state to communicate. And even back then, we shared things with people who were the leaders within the chapters who may or may not have shared additional information. So even today, even though we are better established and networked, as Vanessa said, so you all are at a real advantage in that way, you're still reliant upon the people within your state to share that information with you.
So
and for them to read it, to open it and read it.
We have 8 minutes left.
Okay. I'm Marilyn Novus. I'm the grassroots coordinator for North Carolina, and I do want to say you have done such a tremendous amount of work that we all can learn from, if and when, our own states decide to pursue this. But I did have a thought, just thinking of the tremendous amount of work that you did, and this obviously impacts more than just AADE members. And Jasmine, you touched on this a bit about how in retrospect you wish you had involved some of the other professional groups. So I wanted to ask the other states, did you do that at all or reflecting on it? I know you did a fantastic job of getting the word out, whether or not, and I know how that goes from, whether or not people paid attention. But did you try to our own members, but what about getting the word out to other professional groups? Because it seems like that would lighten the load. I mean, we're spearheading it, but, maybe somebody else could help with this as well. And also, the larger voice might have a stronger impact in getting it.
So in Pennsylvania, and if you do have any kind of this caucus, foundation, or any kind of group like that, we have this Diabetes Action Network. So at the table is a PA Association, JDRF. Lisa and I represent AADE. The Academy is there. So it is a multidisciplinary group. So we have been able, unfortunately, I will have to say our major opponent, which is also the major opponent to our Safe at School, is the PSNA, Pennsylvania State Nurses Association. And I do believe they're scheduled to testify. So I'm really disappointed in that. But we have met with them. We've been reaching out. I do believe is it this coming Friday? There's a conference call with the Academy advocacy folks. So yes, we have done everything that we can to reach out to whatever groups.
And unfortunately, what happens with lobbying a lot of times is you find out who's opposed to your bill 5 minutes before you go into a committee hearing. The lobbyist comes up to you and says, oh, by the way, we're opposed to your bill. It's not the cool thing to do, but people do it all the time. Yes.
Okay,
we have
Mary.
5 minutes left.
Oh, I'm sorry. I was going to say that we did, after our legislation was out there, Bob and I talked to the lobbyist for the Kentucky Nurses Association, who we explained that to her, and right there she said, I don't think that's an issue. The phone calls I got to relate it were from the Hospital Association, concerned that what we were proposing might say that a nurse discharging a patient from the hospital wouldn't be allowed to teach them insulin or this or this or this. And it's like, no. So, after we had a conversation, no, that's within their scope of practice of their nursing license to do those things. And the legislation very clearly states that you would not take any of that away. And so they were fine. So they did not come out against that. And then a couple of other people stayed neutral. Like my team of people at the Department for Public Health, they just did not take a position on it. They didn't take a stance either way. But you want to make sure that you talk to those people. Yeah. And a lot of times it is a little after it's out there. You don't bring those people in before that.
Yeah. 2 questions, and then we'll.
All right, I just want a couple comments. I'm going to make sure I understand 250 hours plus taking the exam. So it's always the hours plus the exam.
In Florida, yes.
In Florida.
And
All
in
right.
Pennsylvania.
Yes. Okay.
And Indiana.
Just, okay. And then if a state was going to pursue this going for licensure, do we notify AADE, like Kurt, do we notify you?
Well, there's a whole lot of groundwork that has to be
Right.
laid
So we just
before
don't start
do
doing
that.
it on our own. And who takes the cost of like the lobbyists? Is it the CB or AADE?
Yes.
And just one suggestion, and I'll get off the thing.
Yeah.
Just an idea that maybe the stage could showcase your stuff at AADE in San Diego at your booths when you showcase your states.
A couple of things on the cost. So in Indiana and Kentucky, I think for the most part, that was covered by sponsorship dollars. In Pennsylvania and in Florida, for the most part, AADE is covering this, and we're looking at this. This is our first real experience. It's not inexpensive These lobbyists range anywhere from $2,000 to $5,000 a month, and they don't want it just in the months when the legislature is open. So you're talking a hefty fee. So our thinking is, we're not going to, I'm not sure where it will go. I think it will always be some kind of shared cost, but we're going to look at it and probably be a model, especially in those states that have funding that can cover a portion of it. It'll be some type of sharing model.
We did have, when I was CB chair before we hired a lobbyist, the CB first off voted, were we following this? We had 100% unanimous agreement. And then we also voted on what we could afford to spend. We've been very, very lucky with the success of our state meetings. So, but it is expensive.
Last question?
Mine's comments, basically. I've got one question. I want everybody to remember, because I was getting very torn up about licensure and that it already went through and there was not a lot we could do about it. In KDN, we had Charles Kendall come to it, and he said, remember, this is a lot like theater. He said, you've got your people in their actors' roles, and that is true. When we go home, we're all colleagues. We all got families. We all have children, many of us. So we got to remember that we may be very passionate about our things, but we are dealing with our colleagues with this. The minimum standard, we need to remember that, and I'm glad that the board has taken a stand on that minimum standard with that, because in Kentucky we don't have a minimum standard, and that's something we've learned. As such, we do have a minimum standard that you don't have to have direct observation, there's no test, and you're going to have 250 hours and you take the core concepts, okay? So I think I'm a quality person, so we've upped that quality of standard that they have to have the minimum of passing the NCBDE. So I know somebody thinks that that's watered down, and I understand that perspective too, but we have to agree on a minimum standard of this. In Kentucky, some of the things we've learned, you don't have to keep your primary license once you're licensed if you choose not to, and that's kind of scary in a way. And also that we did, when we went back the third time, we found out that we can, if the board chooses, go for a regulation where we can put this test into it. So those are things that we have learned about. We thought we had to go back for a statute, but we went back home and kind of looked that over, and when we asked the attorney that, he said no, that if the board chooses to put a regulation out there, they can do that. So those are just some comments I had, since I have been the accompanying burr over here, but I'm the primary burr.
I'd like to thank our panel. Thank you very much.